Good evening to one and all present here. I, Diksha Gambhir from Medisage E-Learning Private Limited, a platform where medical minds unite to elevate knowledge, share wisdom, and embrace digitalization to promote patient management globally, welcomes you to our Med Talk event on the topic Understanding Anal Fistula with our very own renowned expert, Dr. Pankaj Garg. So, welcome, Dr. Pankaj. It is
Thank you.
truly a pleasure to have you with us today. So, to begin with, our audience would like to know from you what's your expertise and why are you considered the number one in Asia and top 5 in the world? Not a small thing at all. Any criteria?
Well, thank you so much, Diksha, for inviting me to talk on anal fistulas. We have been working on this field for last 25 years. And since 2011, we are working exclusively in this field. And I am happy to say that we have over 200 plus research publications, out of which 100 are only on anal fistula. And they are published in all top global journals of US, Europe, Korea, Japan, everywhere. And we have total of 34 innovations, out of which 25 are in the field of anal fistula. And these innovations include new surgical procedures to treat anal fistulas, new treatment concepts, understanding the cardinal principles, how to manage fistulas, discovery of new anatomical spaces. Now, this is very difficult because a lot of new things are coming in treatment part, but discovering something new in anatomy, because medical science as a treatment part started after 1800, but anatomy started in 1400, 1500. So anatomy has been almost, you can say, deciphered, known well 200 years back. And only microscopic part was discovered 100 years back. So discovering anything new in anatomy is very, very, very rare. So we have discovered new anatomical spaces and which have been published in top American journals. So due to these, we are considered in the top 5 in the world because we have the maximum publications in the world. But apart from that, there's a very interesting group of doctors. A few of them are from Stanford and John Hopkins, I think. They are working, they have like a website called expertscape.com. It does something very interesting. It ranks doctors across all specialties of medicine and across each subspecialty on each topic. And it ranks them in world level, continent level, country level. So obviously they do that for fistulas. And I would like to share the screen that this is, you can see the expertscape.com. So this is expertscape.com. And this is an American website. And we have selected rectal fistulas here, right? And in rectal fistulas, we are seeing the ranking at Asia level. And you can see Pankaj Garg is at the top. Then there's a Chinese one, then there's a Japanese one. So these is the red color is Asia. So these are the Asian rankings. And then there is a worldwide ranking. You can see rectal fistula, worldwide rankings. So all these are people from the topmost institutes. We are at number 4 in top 5 in the global ranking. So Emmy Leitner is the chief of Cleveland. Phil Tauser is chief of St. Mark's, London. David Schwartz is from Illinois, University of Chicago. So rest all are from America, Europe. So we have put Indian map right at the top. So that is why when we say that we are in top 5 in the world, that is not based on any presumption, that is based on actual data. So nobody else has worked so much innovations across the globe. And so that's why now not only we're giving lectures all across the world, the governments of many countries now are officially inviting me to teach surgeons there. I was invited by Kuwait government, then Italian government, Russian. So we have been to these countries, Korean, and going on the state expense as a state guest and teaching surgeons there. So, and it's a very challenging field as we'll discuss now. So that's why it's always good that you work in one area, but you become and the best in that at the global level.
Yes. So awesome, Doctor. Heartiest congratulations for your achievements and for making India proud. I think you have done a very, very commendable job, and we are really proud of you. And we are very happy to have you here talk on your expertise with our audience.
Thank you
So
so much.
pleasure, Doctor. Pleasure. So now moving on to the topic that we're here for is understanding anal fistula right from the expert. So what is fistula? Let's begin from the basics.
Right. Very right. Fistula, by definition, means connection between two surfaces. That fistula can be in the any part of the body. It can be the brain, in the lungs, anywhere in the intestines. So it connects two surfaces or two organs. So that's technically a fistula. So when we talk of anal fistula, what are the two things it connect? So it's basically a bypass tract which connects the rectum with the skin. So normally we have all the fecal matter, we pass motion through the anal canal to the anus. There's no connection, abnormal connection. So fistula is an abnormal tube-like bypass tract between the rectum and the skin. So that is called anal fistula. So then the question comes, why it is pathological? What harm does it does? So rectum is full of bacteria. It is perhaps the organ with maximum bacteria in the body. Ironically, surprisingly, just adjacent to rectum is the urine tract. Urine tract is sterile. There's not even a single bacteria in 1 liter of urine. On the contrary, the rectum, 1 ml of fecal material has 10 raised to power 12 bacteria, which amounts to 1,000 trillion bacteria per ml of fecal matter. So that's why females have more UTI, urinary tract infection, because of the proximity to the anal canal. So, but the God has made such wonderful defenses of the rectum that not a single bacteria can penetrate the wall of the rectum. So all bacteria remain confined to that area and pass out on daily basis. Now, what happens when a fistula is formed? So you, as I explained, there's an abnormal channel or a tract or a tube-like passage going from the rectum to the skin. Now what happens? Normally the bacteria which cannot penetrate the wall, they have access to the wall of the rectum. So they enter that fistula tract and it is not, it's stagnant, stagnation is there. So they multiply. They have got the space to multiply. They multiply, they make pus, bad, foul-smelling pus, and it gets collected there, it causes pain, or it comes out through the skin opening. So that's how it keeps on spreading like a termite. It can spread upward, downwards, and when it abscess acute stages there, it can pain a lot, it can cause septicemia and even death. So that's why fistula is a bad disease and it needs to be treated. Don't get scared.
So why it happens? I mean, what are the causes that we all need to know and be careful about? What
Yeah.
are the causes basically?
Yes. Now, that is very important. First question comes to mind. What are the causes of fistula? But unfortunately, the microscopic cause is that there are glands inside the anal canal which secretes mucus because there's a lot of lubrication there. Otherwise, the fecal matter will get stuck there. So those glands, it is believed, that's a hypothesis, it gets blocked. It gets blocked, the secretions accumulate. Now, because there are a lot of bacteria there, as I just explained, the even whenever there's stagnation, it's going to be a problem, whether in the body, anywhere, or outside, when there is water, there's mosquitoes. So that stagnation, because of the blocked gland, gets infected and forms an abscess. And when that abscess ruptures inside the rectum and outside on the skin, it forms a fistula. Now, obviously, the question comes why it gets blocked. So, well, nobody knows that. It's a sheer of bad luck. But some of the speculated other causes are constipation. If you have hard stools, it rubs, it causes injury, and bacteria can enter. Then even non-veg, too much of non-vegetarian food. Then even smoking has been linked to it. So these are the speculated reasons. Then another I would like to say is the water jet. This is our discovery, which was published 15 years back in the top British journal. You know, water jet, very common in Indian subcontinent. Shower is fine, but a lot of Indian people use water jet in the toilet seat. Western commode, you see the jet which is fixed behind. That is very dangerous because it hits the same spot every day, causes injury, causes fissure, and can cause fistula. You remember there used to be hand pumps long time back, and in front of the hand pump, on the concrete floor where water used to fall, there used to be a pit. Even in the concrete, water would cause pits. So when water pressure can cause pits in the concrete, why won't it damage the soft skin or mucosa, what we call inside the anal canal? So for the first time, we discovered and published it, and people were really surprised. But now we are strongly advocating to stop using water jet. Shower is fine because it is not one stream; it is multiple streams. It doesn't hit the same spot every day. So hand shower is absolutely fine, but water jet should be condemned and be prohibited by the government, banned by the government, right?
Doctor, every disease has some symptoms, you know. So
Can you
what
please
are
a
the
bit louder?
symptoms of?
Your voice is less. Yeah,
Yeah, I'm audible.
this is better.
Uh, out. Yeah. So I'm saying, doctor, every disease has some symptoms. So I'm sure fistula also has some symptoms. How do we come to know that this is fistula?
Look, good question. And I would like just to summarize because of the two other problems associated with people often confuse. One is hemorrhoids called piles, the other is fissure, the third is fistula. I will just briefly tell the difference so that people can understand.
Hmm.
Piles is primarily engorgement of veins. So it causes only two symptoms. Either the veins come down while passing motion, there's something is coming out small like pee or something like that area, or they can burst and cause bleeding. So piles has two symptoms, prolapse or bleeding. Piles are painless. Second is fissure. Fissure is a cut or an injury due to hard stool or due to water jet. It has the cardinal symptom of fissure is pain, severe pain. The third is fistula, which we are talking about. The cardinal symptom of fistula is pus. As I just told you, it's pus. 99% time it's painless. So if no pus patient comes to me and says, sir, I have fistula, I have been told I have a fistula, but for 10 years I have no pus. I said, forget, you don't have a fistula. So the cardinal symptom of fistula is pus, no pain. Only when the pus accumulates and forms an abscess, there can be pain. So as a thumb rule, the pus is a cardinal symptom of fistula. It's a bad disease. Just imagine like a lot of dirty pus coming around that area. You have to keep cotton, never feeling normal. So it's a really bad disease to have. Any disease is bad, but I have patients coming from all over the world. We have treated patients from 46 countries in last 5 years, and they were not medical tourism. Like medical tourism is people coming to India that it's a cheaper treatment. Let's go to India. So that's medical tourism. These are people who came to India Dr. Garg, we are not getting all right. Where are you? In Chandigarh, India, North India, we're coming to you for expertise. So people coming to me and they said, one patient came from US. He said, that lady said, I'm a patient of breast cancer. My husband had a triple vessel bypass, but fistula is worse than both. So it's a bad disease, right?
Okay. So is there anything more that you can elaborate why it is bad? Is it like you said about pus? Is pus the only thing that makes it bad?
No, we're coming to the next step. Next step is treatment. It is bad because of its treatment. I will come to that. It's the paradox because eradicating a fistula is very challenging. So that's why it is bad. I will explain that. This is a very important concept which people should understand.
Have you come across any complicated case, like a bad case or a unique
Yes,
one recently, that you can discuss with the audience for a better understanding of the entire concept?
yes. Normally bad cases come to me. Rarely we get good cases because we get a referral center. So all across the world, the patients, they come to us are the patients who have been referred across. So can you see this? I will.
Yes, I can see.
Okay, this is
Tiger.
a good diagram. So you
Yes.
see, this is the patient. This is the anal canal. This is a vertical diagram that there are two muscles. This is the an anal canal. There are two set of muscles, two rings, you can say. Yeah, this is a cut section. So this is the outer muscle. This is the inner muscle, right? And the fistula tract, as you said, this is the opening in the rectum. It comes out, and here it is opening in the skin. So bacteria enters from here, multiplies and comes here. So this is the amount of the sphincter muscle which controls the motion. So that is the thing that sphincter muscle is very important, which controls the motion has to be saved. Now, as you can see, the fistula tract is involving the muscle, and if some surgeon cuts this muscle, the patient will lose control over his motion. So that is why the treatment of fistula is very challenging. I will show you some look. Fistula can spread like termite. I'm rapidly down. It can spread in any direction. We have these very complicated patients going up, going inside the tummy, going in the back. So this is relatively opening into the vagina. You can see rectovaginal fistula, and again this is opening high fistula involving 100% of the sphincter, grade 5. So these are the all complicated fistula diagrams you can see, and these are fistulas which normally are not managed by almost any center and are being referred to us. And so now coming back to the thing. So this is a grade 5 suprasphincteric fistula, almost 100% of the sphincter is involved. So now the biggest challenges of fistula is that you have to save the sphincter, and you have to still, because as you saw, the fistula is crossing into the sphincter. So you have to cure the fistula, but save the sphincter. And because of the, you saw the diagram, there were multiple branches, and you leave even one branch, the fistula will come back. So this is called a recurrence. Recurrence means the fistula has come back. So the two most important problems in treating fistula are incontinence, means the losing control over the bowel motion. Continence is the control over the motion. Incontinence is loss of control over the motions. So the two biggest problems of fistula treatment are incontinence and recurrence. So because of these two things, fistula treatment is very, very difficult. Now, here I would like to emphasize one point that I always in my lectures tell thing that there are two types of fistula, not one. One is simple, one is complex. Simple fistula means a low fistula, very little sphincter is involved, single branch. These can be managed anywhere. Any primary center, any hospital, any surgeon can manage, lay open that, sphincter is not involved, fistula will become all right. But 25% of fistulas are complex. And if you try to meddle with that, you can really, really cause damage to the sphincter, and even fistula will not heal. So we always tell in our lectures that simple fistula, you please manage. This is a message to all surgeons across India and across the globe. That is a simple fistula, 75% fistulas are simple, you please manage, don't refer. But if it's a complex fistula, do not meddle with it. You will make the life of the patient miserable, and even you will not feel good. Let it be managed at a center which is exclusively managing fistulas, because complex fistulas is altogether a different disease. So it should be managed by fistula expert surgeons. And we daily get patients who sphincter has been cut, young girls, young boys, and they have lost control. So it is very, very painful. People are using cutting ceton, they're using threads, cutting cetons, and cutting the whole sphincter. And we are seeing so many patients of like that. So complex fistulas should be managed by fistula experts, and simple fistulas may be managed anywhere. That should be the key take-home message. We have patients who have come from US, Canada, operated 14 times, 15 times, 20 times. And we have patients, even yesterday, patient came, they make a fecal passage in the tummy, which is called a colostomy or ileostomy. And we were so pained to see that. Like surgeons, a lot of old time surgeons or even present surgeons think that if you divert and make a passage here, the patient will become all right. And patient doesn't. So you have created a problem which is bigger than fistula. So it is very troubling that way. So one should be very, very careful of referring, knowing when to refer the patient. Right? That's why you can understand now why it is a bad disease. Your voice is not audible. Yeah.
So, doctor, can we also refer the complex fistula as life-threatening also?
Well, I always tell my patients fistula is rarely life-threatening. It's a bad disease because it's difficult to treat. It keeps on coming back.
Worse.
And it causes bad symptoms because if the sphincter is cut. But rarely, and after 10 years, the chances of cancer formation are higher in fistula. But if you leave that, fistula is and acute abscess formation leads to septicemia and shock. Fistula is not life-threatening, but it makes the life miserable.
Okay. And doctor, what about quacks? Are the quacks dangerous?
Well, quacks is I'm not sure whether it's the right word or not. Quack, I'm not sure how to qualify quacks. A lot of questions what you have asked about quacks, but I don't feel like that anybody who's been given license by the government, person who has been not licensed, who's not a surgeon of any specialty, of any system, medical system, he's a quack. So even quacks are there in this field, because you know that in India, there used to be Bengali doctor who have just compounders and sitting and doing treatment. So those are the quacks. So unfortunately, along with that, I would like to add another thing, that even today, some patients, not all, feel this is a taboo and do not openly come and discuss about this problem. And I think in today's world, one should not think that any disease, maybe it's a psychiatric illness like depression, or an perianal disease, or a sexually transmitted disease, should be a taboo. It's a disease. It can happen to anyone. So when something can happen to anyone without your fault, then how it's a taboo? It is not. So one should openly come and discuss it, and one should always see the qualification of the surgeon, the experience of the surgeon, and not go by the tall claims. I can only advise that if you have a simple fistula, go to a good surgeon in your city. But if you have a complex fistula, before deciding where to get operated, you should always try to see how many that surgeon has treated complex fistulas and be very careful. So, and obviously quacks, I defined people who are not qualified and doing, one should never, because they can make big claims that we can treat fistula 100%. No center in the world can give guarantee because microscopic branches can still remain. So if someone is claiming 100%, he's most likely a quack. Because there's a saying in surgery that a surgeon who says he has never had any complications, either he's lying or he has not operated enough. So same thing goes with the quacks.
Well said, Doctor. Doctor, I would like to also know, like, how to analyze and know whether a fistula is low or high in severity.
Very
Is there a way
important.
to measure?
Yes, very important. Because severity, as I was constantly using the term simple and complex. So your question, if it's, we can reframe, like how can a patient know whether it's a simple fistula or a complex fistula?
Exactly.
Surgeon expert would know, but how does patient know? Well,
Yeah.
and what you asked was a very precise and a good question. It depends on the amount of sphincter involvement. If sphincter involvement is minimum, then you can lay it open and it's a simple fistula. If sphincter involvement is more, fistula is going high, so then it is called a complex fistula. So by definition, which we also corroborated and given by all surgical societies, the main sphincter, if it less than one third of that sphincter is involved, fistula is only one less than one third, then it is considered a low or a simple fistula. And if more than one third of the sphincter is involved, it is considered high or complex fistula. So that is the basis of now new classification which we have given and is published in all textbooks. It's known as Garg classification, and it is now being followed at several centers across the world, and in which we change the concept how the fistula should be classified, and primarily made into high and low fistulas, and one third is the cutoff. So many times by feeling, expert can tell that whether it's a low or a high fistula, but the gold standard is MRI. So always, whenever in doubt, we should get an MRI done. And we are in India, we are really fortunate because MRI is very economical in India. You might find it's at 6 to 6.5 thousand rupees. You might find that it's not economical, it's costly. But when I go to different countries across the world, you won't believe in the US it is 5,000 to 10,000 US dollars. In Europe it is 2,000 to 6,000 pounds and euros. So when we see that, then we feel it is really very economical in India. So we should make use of it. And in charitable center, it is up to 3,000 rupees a MRI. So MRI is the gold standard. And we have done extensive work in MRI and fistulas. We have written guidelines for the radiologist. Now we have so much experience in this field that's rare for a surgeon to write guidelines for the radiologist. Now we have written guidelines how to read fistulas in MRI in fistulas, and they are followed by radiologists all across the world.
Okay. Now, Doctor, we have understood about simple and complex, high, low, and the severity of fistula. Now it's time that we understand how to treat it,
Yes.
especially the complex fistula.
Like we, as I said, there are two types of fistula: simple and complex. It's simple is a low fistula. So low fistula, gold standard is fistula, means that you can lay it open, and that's the first surgical procedure taught to all surgeons across the world. So low fistulas can be laid open, and they heal by the success rate is more than 95 to 98%. But complex fistulas you cannot lay open, because if you lay open, you will cut the sphincter, and the patient will become incontinent. So there lies the problem. So in last 50 years, lot of different procedures, new gadgets have come across all across the world. And in this field, we have worked extensively. And we have innovated a very, very good procedure, which is called TROPIS. We are the inventor, it's copyright in our name. It's copyrighted in my name. And this procedure has one of the highest success rate in complex fistulas across the world. Now, this is being replicated in 2022, Switzerland journal, Frontiers of Surgery, meta-analysis was done of all the new procedures done for complex fistulas. Meta-analysis means analysis. And they found that TROPIS has the highest success rate. There are many procedures like laser, like lift is ligation of the sphincteric tract, like waft, which is endoscopic, anal fistula plug, stem cells, and it is a matter of proud that our procedure was found to be have the highest success rate of all the procedures. So a lot of people now you have asked this, come and ask about laser. And laser is again a company-driven initiative, I would say. I'm sorry to say that. People, even you would think that laser, people think we have laser. That laser is something like rays, they will shower and fistula will close. So I would like to clarify, laser is not something magic. Laser is an instrument which is a cutting instrument. Laser is only what it causes. It's a precise cutting. Cutting is precise. So laser, what it does is that it, apart from electrocautery, it is a little more precise. And again, it is the expertise of the surgeon who is holding the laser. With what you can do different procedures with laser. You can cut like this, it will become a different procedure. You will cut like this, it will become a different procedure. So the way advertisement is done, we have laser. People think that laser will do everything. It's not that simple. If you, Neeraj Chopra won gold medal in javelin throw for India last Olympics. Now you give me his javelin throw, will I be able to win Olympics? Gold medal in Olympics? No. It's not the javelin, it's the person who's holding the javelin. So it's not the laser machine which will work wonders, it's the person who is holding the laser thing. So that's why we never advertise we are having laser, because that is misleading people. So that treatment is the first thing in complex fistula, sphincter should not be cut. That guarantee surgeon has to give. Second, the recurrence rate should be minimized. Nobody can tell that it can be zero, but it should be minimized. Third, the pain should be less. Fourth, patient should be able to work early. Most of our patients are go back to work the next day. Fifth, the wound should be small. So we have made this priority list, and this is displayed in our center, in our Garg Fistula Research Institute. Like we have exclusive fistula managing center, which is one of the perhaps only one in the world, which is managing fistulas and from patients all across the world. It's known as GFRI, Garg Fistula Research Institute, and the maximum number of patients and maximum number of research, inventions, and discoveries are coming from GFRI all across the world.
Great. Awesome to know that. So, Doctor, is there any like without surgery treatment that you talked about?
Yes. Now that is a very important question, because everyone would like to know answer about that. Can we treat fistula without surgery? Now we have worked extensively on treating piles and fissures, hemorrhoids and fissures without surgery, and we have been successful to a great extent. Lot of grade 3 hemorrhoid or piles and refractory advanced fissures, more than 99%, I would say, we are able to treat without surgery. Fistulas, as a rule of thumb, cannot be treated without surgery. But again, we are trying level hard to the best of our ability to find a cure of fistulas without surgery. We have got little success in the beginning now. We are able to treat a small subset of fistulas without surgery. And we have published this in last year in Australian New Zealand Journal of Surgery. And this is definitely a great beginning, I would say, a small but a great beginning, and a great news for fistula patients across the world that we have been able to treat some fistulas without surgery. And I'm very hopeful that we should be able to find treatment of fistulas without surgery soon. And a lot of my surgical colleagues joke and ridicule me that what kind of surgeon are you? That you are treating surgical diseases without surgery with medicines. You're not a good true surgeon. But I always say that look, surgery should not be done when it can be done. It should be done when it's the last option. Surgeon might be any great, but he cannot do a job better than God. So the thing which God have made should only be meddled when there's no other option left. That's my personal thinking.
Okay, so as we're talking, doctor, we have a question related to the process. So a doctor is asking, Dr. Lalchand, he wants to know how fistula get into rectal fossa. That's the question.
Well, the fistula, as I said, starts from the inside in the gland, then there's a sphincter, and outside is the rectal fossa, is the fat. So when fistula spread forms an abscess because of pressure can cut across the sphincter, and when cross goes across the sphincter, it forms and enters the rectal fossa. So it's basically the pressure of the pus in the abscess which pushes it into the rectal fossa. Now, I was talking of the new space which we have discovered. The covering of the sphincter has a fascia. Fascia means a thin layer of tissue. So sometimes what we discovered for the first time, that between the sphincter and that fascia, which is now known as, in both journals, it's been published as Garg fascia, named after me, that there's a space called outer sphincter space, and fistula can spread there as well without entering the rectal fossa. But it pierces through that, it enters the rectal fossa, right?
So, doctor, as we were talking about the procedures, so there is a doctor, Dr. Sahu, who wants to know about a lift procedure. So could you just elaborate it a little bit for him?
Yes. Lift procedure, lift stands for ligation of intersphincteric fistula tract. This was devised by my very good friend, Arun Rojanasukal from Thailand. And basically, what its lift procedure is done is that there are two sphincters I told. So rather than cutting through the sphincters, he gave that we go between the sphincters and ligate, means tie the fistula tract. So in simple fistula, results are very good, but in complex fistula, results are good. In Dr. Rajna Sokal series, results are around 80 to 90%, but different studies across the world, the results are between 40 to 60%. And technically doing it is a little difficult. So that's why lift procedure has not become very popular across the world.
Okay. Thank you so much, doctor, for answering questions of our audiences. So moving to the next question. So now we have understood the concept, we have known about the procedures, treatment. So now it's time to tell the audience about some tips and suggestions for our fistula patients.
Well, as I said, that important thing for fistula patients is that don't delay treatment, because people fear, they have, whoever develop fistula goes on their Google on the internet and sees the complications, harrowing experiences of patients, and so they get very much frightened and fearful. So do not get fearful, but I always say one thing: if second step is to decide you have a simple or a complex fistula. If you think you have a complex fistula, better to go to an expert. And if you can't, then do not get it meddled by anyone, because he will end up complicating it further. So the choice of the right expert is paramount and fundamental if you have a complex fistula. So be very careful, better avoid surgery for some time, but do not get caught in a kind of a whirlpool where your fistula gets more and more complicated because of the treatment. So that is the important thing. Do not get fearful, get your assessment properly, go to the right expert if you have a complex fistula, and fistula is treatable. Because many patients come to me from UK, US, Canada, they said, "Well, sir, we have been told it's incurable." No, no fistula is incurable. All fistulas are curable, though nobody can guarantee them cure in the first go, but majority of our patients are cured in first go, but some of them, very, very small percentage have to be operated again.
So I think that the topic has been very well explained by the expert himself, and it's now time to move towards the closure. So, Doctor, thank you so much for sharing your valuable time and insights. Your session provided us with a deeper understanding of today's topic, and I'm confident that every attendee has gained significant knowledge through your experience. So, thank you so much for being here with us, and looking forward for more such talk shows with you on interesting topic like today's. Thank you so much, Doctor.
Thanks once again, Diksha, for calling me and sharing my views. It has indeed been a great pleasure. Thank you so much. Bye-bye.
Thank you, Doctor. Namaste.